All right, well, welcome to our next episode for the MRC Advice Guys. This episode we have actually one of our friends, Rich Fovo from Joint Fit Chiropractic, and we are going to be talking about some injuries today. Primarily, one of the things that a lot of people come in with into our stores with plantar fasciitis. So why don't we do this? Rich, thanks for being here. Why don't we first talk about what is plantar fasciitis? Tell us a little bit about it.
Okay. Well, there's a lot of conditions that can present as heel pain, and so particularly with plantar fasciitis, if we establish that's what the diagnosis is, that's kind of a failed adaptive response to healing where the plantar fascia attaches to the heel bone. Alright, so the plantar fascia is like a thick band that travels across the bottom of the foot. Its function is to provide stability to what's called the plantar vault. You have this arch here they call the plantar vault, and it's supposed to be a dynamic machine, and the fascia is helpful in maintaining the structure and the integrity of that arch. Now it's a passive structure, so it's not supposed to bear a lot of weight, but one condition or another, we can talk about that a little bit more, but what happens is a lot of stress is generated where that band attaches to the heel. And so there's a little interface here where these cells are transitioning into the bone. And so there's a couple different ways that plantar fasciitis can present. It can be this really thick acute swelling of the plantar fascia right here. It can also be more of a thickening with kind of a degenerative change going on within the tissue itself. And then it can also just be more of pain, tightness, inflammation in the mid part of the fascia as well. And that's actually a lot easier to deal with.
Is there something that's more common than other things? Because we have a lot of people coming here and like one of the first things they'll say is, I wake up in the morning and first step out of bed is killing me. Is that, we're all talking about the same thing here. That's, I mean, when you're talking, whether it's be back in the heel or through the middle of the foot.
All three of those can present the same exact way.
Okay.
And that kind of makes treatment a little tricky because you don't treat all of those exactly the same. And some of those respond a whole lot better to conservative care than others.
Mm-hmm.
So we find, at least I seems to be the case, happens more in the summer. Is it people wearing flip-flops or shoes that just aren't supportive? Does that have anything to do with like an increase in the summer, it seems like?
That certainly could be the case. With flip-flops, there's not a lot of resistance to the motion called dorsiflexion. And so some biomechanical studies suggested that the number one predictive factor for somebody that develops plantar fasciitis is the speed at which their toes dorsiflex during gait. And so during the flip-flop wearing season, obviously there's not a lot down there. And so when the foot strikes, a lot of times the speed of dorsiflexion is pretty high. And sometimes it's even exaggerated because the toes may be in a dorsiflex position to try and hold the flip-flop on the foot.
That's interesting. So, and then we've got a couple shoes here too. So one of the things we have, whether it be podiatrists or just regular, family doctors will send people in and say, hey, we want to get you in a arch support, maybe their shoe is overdue for being changed, or maybe it's the wrong type of shoe. Whenever I'm talking with somebody, those things can be important, I think, and you can kind of go to how important they are. But the other thing I always say is you need to be aggressive with it. You need to get in and see someone, whether it be yourself or a massage therapist or somebody that can actually work on it itself. Be aggressive with it and try to get it healed.
Yeah, I would agree with that. The first most important thing is probably to figure out what exactly the proper diagnosis is,
Mm-hmm.
and then have somebody really good with gait, running gait, walking gait, take a look at it, whether it's physical therapists that are real good at that, or somebody like our office. We do a lot of that stuff. Anyway, the one thing that we have available is we use diagnostic ultrasound, so we can put eyes on the tissue and see, okay, how thick is it? How bad is it? Do you need to go see somebody to get a steroid shot in there? Would you do better with maybe some kind of PRP or something like that? Or do you have a spur that's responsible for some of this? Or is the fascia fine? Is the spur, and there's no spur, then what's causing the pain? Is it fat pad inflammation? So a lot of things can masquerade as plantar fasciitis. So great tool, diagnostic ultrasound, lets us see exactly what's going on. Secondly, with the gait analysis and that kind of stuff, we can take a look at the structure of the foot. because there's a lot of faulty structures, like a short first metatarsal or a long second metatarsal, or phalanges on the second toe, maybe longer than the first, that can contribute to a biomechanical problem that just predisposes you to overstressing the plantar fascia. If we can figure out whether it's a forefoot problem or if it's a rear foot problem, like that there's too much pernicious at the heel, then we can make better recommendations about sending people over to guys like you, say, hey, they've got a rear foot problem or forefoot problem. What kind of shoes do you have that would provide extra support or stability to that? Additionally, there may be a prescriptive orthotic that we may be able to write that even an orthotist may have to design for some people that have these structural problems to put in their quality running shoes. But we want to figure out what's causing it. Yeah. And it's not just always in the foot. Sometimes we got to travel up the kinetic chain and look at the function of the hip, how well the hip rotators are firing and stabilizing the entire limb. So we want to take a good look at those things and then make the recommendations from there. But it usually takes, a big scope. You have to take a broad look at the whole picture.
Right.
And then certainly shoe wear and even supportive braces like this. People have a lot of sometimes good results with wearing this. Sometimes we keep it taped too for a few weeks just to offload the fascia. But usually as much as you can throw at it, as aggressive and as early as possible, you're going to have a better outcome.
Yep. So I've been seeing you for a few issues I've been having with my leg, but I'm also running quite a bit right now. So someone listen to this, they're running a decent amount, and then for everybody that's different, but running a decent amount, and they want to obviously prevent from getting something like this. Is there something you would say, whether it be stretching or strengthening or massage techniques, even if they're doing their own stuff, just on their, is there something that you would recommend?
Yeah, so some of the big things with this, just locally starting with this, is strength of the intrinsic muscles of the foot. You can start doing some strengthening exercises where you're gripping the ground, trying to keep the digits down, strengthening the toe flexors. We talked about the toe extensors or the dorsiflexors. Firing too quickly being a predictive factor. So if we can slow that down by strengthening the toe flexors and the arch stabilizers, that would go a long way. Those types of exercises. Just mobility work through the tissue. That fascia gets very thick and tight, so rolling on lacrosse balls, and there's all kinds of spike therapeutic tools you can purchase for that kind of thing. Really mobilizing the soft tissue of the calf too will make sure that you have good proper dorsiflexion of the ankle. Sometimes what happens is we overuse the toe extensors when the ankle extensors aren't getting the job done, and so that could be impaired by tightness in the gastroc and soleus. So a lot of calf stretching dynamically, as well as statically in different planes, not just forward, but maybe getting into it and then doing some rotational movements, some lateral in the frontal plane as well. Trying to stretch the tissues in 3 dimensions is a good idea because we're 3-dimensional beings.
So one of those exercises you're talking about, gripping the ground, I think back when I was in school, they always told us to put like a towel on the ground and kind of pull it with your toes. Is that's a good one to do?
Yeah, there's a lot of ways to go about that. That's a very common one. Another would be to maybe put some nuts and bolts on the ground and practice gripping them and putting them in a box.
Your kids' Legos?
Yeah, there you go. Be careful with that one. They're sharp. But yeah, that would be a good way to do it. Additionally, I like to have people put their foot up on a table like this and put like a TheraBand over the toes and pin it under the heel so they can pull that back, fan the toes out, and practice that toe flexion and then that slow return back upward so that we can build that eccentric strength of the toe flexors.
Yep.
Those are good ways to do that.
Cool.
As far as like footwear, you have some shoes here. You want to just talk about like the differences and ones that may attribute or have more cause to attribute to plantar fasciitis? Maybe?
So I don't want these to be an endorsement of a particular brand because that's not what I'm here for. But so one example, though, is what we're talking about is sometimes when it's the speed of dorsiflexion causing the problem. A shoe that has a very flexible forefoot will not help that. And so what we look at is to do the squeeze test. You just put a little pressure just like this and you just look at how easily that forefoot will dorsiflex. and you can do the same thing on the table. And it doesn't take a great deal of pressure to get a nice amount of dorsiflexion through the toe box. Okay, and then just for comparison, this is the shoe I picked up over there. I can push down pretty solidly on that, and that thing doesn't dorsiflex much at all. And so, just in the sometimes acute phase, I try to get people in a stiff-soled shoe initially to slow down that dorsiflexion while we're supporting the fascia and doing all the other protective and healing and therapeutic activities that we're trying to do to fix that. Sometimes we put a steel plate in the shoe as well. That'll really slow it down. If they love a particular brand and they want something like that, we'll put like a little insole on the bottom of that. It's really rigid.
Yep. Yeah, those are all good things.
So as far as like, we have a lot of insoles and those can help. As far as that, I mean, do you have a different strategy for when it's starting versus when you've just gotten over it? Like, do you like to start with a really rigid one and then as they build the strength up, maybe go to something that's a little less rigid so that they don't have to have that super hard, but maybe they don't want it to come back? Because we have all varieties. We have, ones that bend with your foot, and then we have ones that basically are like putting a splint on your foot. Is one better for like, it's just starting, you want it to heal, and then maybe switching to type, or what do you like to do?
I think that would really depend upon the structure of the foot. If they have a foot that's super flat, but yet it's rigid, and then when they go up on a toe raise, and if that arch doesn't bow, it stays flat in both positions, they may do better with a more flexible one. It may not, if it's super rigid and they've got a rigid flat foot, you may run into an issue where if they get too hard of an insole, you may get some stress on the navicular or irritate the soft tissues a little bit more.
Okay.
So I would go more flexible on somebody like that. If it's somebody that has a real a high arch, I think that it really just depends on what it looks like when they're walking.
Okay.
If it's someone that just has a high arch and then they're collapsing completely during their running gait, I would probably go more rigid because they need that. But
So it's more individualized
really
to the
is.
foot versus like beginning or ending stages of the
yeah,
of it. Okay.
and a lot of people run, and the rear foot won't hit the ground. It's the forefoot, and so we can't avoid or neglect the forefoot.
Right.
A lot of insoles that we have are really good at correcting problems at the rear
Yep.
if the heel is overpronating. Sometimes that's just not the cause of the overpronation though, and so it just takes a little bit closer eye. And then there's some shoes that do a good job of creating like a forefoot varus post that addresses forefoot overpronation. And so we've sent some people over here for shoes like that, so you guys are pretty familiar with those. But it really is a case-by-case basis. But the exercises are usually helpful for anybody with the problem. Sometimes if it's really, really swollen, we'll recommend a night guard or something like that to keep them in that vertical position.
So it doesn't hurt so bad in the morning?
Yeah, because what happens is normally when they lay down, our feet are pointed down because of the way the sheets or just the way that our ankles are positioned in bed. And so our calf ends up getting tight overnight. A lot of that fascia is continuous with the fascia on the bottom of the foot. And also that contributes to a loss of dorsiflexion at the ankle. And so you get out of bed with those calves stiff and those toes start dorsiflexing too fast, it really starts pulling on that. So that helps maintain the dorsiflexion that you've been working hard at getting in the ankle joint. So that's a pretty useful tool sometimes for really bad cases.
Excellent. Well, that's probably more information than people even really wanted, but that definitely gets you going. Actually, it's really good stuff. I have to admit, a lot of times when I have injuries popping up, if I get on them right away, like I had something going on the inside part of my left groin or right groin, and I mean, I came in and saw you within a week of it starting to happen, and I haven't had any issues since. So I mean, I think a lot of it's maintenance, a lot of it's getting on it early, being aggressive. You just gotta find, and there's obviously a lot of really good doctors out there that can do a lot of really good stuff. It may hurt in the moment when you're doing it, but if it takes care of it, so you can get out there and continue to enjoy your running or CrossFit or just lifting weights or just walking or whatever it might be, just got to get on it and take care of it. So.
And especially I think with plantar fasciitis, it seems like one of those ones that can linger
Oh,
for
yeah.
a long time if you
Yeah.
if you don't get on it quickly, like
Really.
months.
It really can,
So-
and once that swelling gets up there to a sizable amount, it gets more and more difficult to manage. And then, not to mention though, and it's very common for people to have it in both feet, because as they get one foot that's painful, then they start offloading
Yep.
to the other leg, and then that one can get strained, or
Yeah.
else they'll start running on the outside of their foot, and then you start running into stress injuries on the fifth metatarsal.
Yep.
Mhm.
So it's just, it can create a cascade of problems, and the sooner you get to it, the better.
Yep.
Cool. Well, if you have any specific questions, feel free to tag them on this video, send them to any of our social media, and if we can get Rich to answer those, or if we can answer them, then we can get back to you if you have any specific ones, or if you have you have it and you need recommendations on places to go, like seeing Rich, or if he has somewhere where he would send you to. So send in your questions, or if you're dealing with similar issues and want to find an answer.
Yep. Appreciate you coming.
Yeah, thanks
Thanks,
Rich.
guys.
Thanks a lot.
Yeah.
Appreciate
Thanks,
it.
Trey.
Yep.